This is TTT Live. I am DK Rosta. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Talk City 91.1 FM, Sweet 100.1 FM, Next 99.1 FM, and on Facebook at TTT Live Online. Now over to the Minister of Communications, Donna Cox.
Good morning and welcome to today's virtual media conference to apprise you of government's efforts to combat COVID-19. Today with me are the Minister of Health, the Honorable Terence Dialsing, Dr. Christine Carrington, Professor of Molecular Genetics and Virology, and Head of the Department of Preclinical Sciences, Faculty of Medical Sciences at the University of the West Indies, and Professor Terence Simangal, Dean of the Faculty of Medical Sciences, University of the West Indies. The Minister of Health, the Honorable Terence Dialsing, will provide an update on COVID-19 in Trinidad and Tobago.
Thank you very much, Minister Cox. Good morning to ladies and gentlemen of the media and to the listening and viewing public, wherever you may be. I also want to welcome the two esteemed colleagues from the University of the West Indies, and I hope you make full use of their presence here today. So where are we with coronavirus? As of today, Thursday, 30th of April 2020, the world has recorded 3,245,791 cases. The number of deaths globally stands at 229,220. And the number of people recovered around the world, 1,016,442. What is Trinidad and Tobago's position in all of this? You may recall that we have started to ramp up our surveillance testing. As of yesterday afternoon, we conducted 212 such surveillance tests across Trinidad and Tobago, and all tests to date have come back as negative. So, of those 212 in the communities at one health center per county in Trinidad and one in Tobago, all 212 tests have come back negative. The total number of tests done to date, 1,683. Total number of unique patient tests, 1,376. Total number of repeated tests, 307. Total number of positive cases stands the same at 116. Total number of discharges, 72. Total number of deaths, thankfully, have remained the same at 8. 7 in Trinidad, 1 in Tobago. Total number of hospitalized patients has dropped from 9 to 6, and all 6 are in Couva. There's no one in either the intensive care unit or the high dependency unit. No one is on a ventilator. All 6 are mild asymptomatic patients, and we wish them the best going forward for their discharge. At the Sangre Grande Center in Brooklyn, we are down from a high of 28 to now 8 patients, all asymptomatic, low risk, all stable, and we wish them the best of luck so that they can leave that center as soon as possible and resume life as normal. Home of football in Couva, 22 patients, asymptomatic, low risk, all stable. And in Tacarigua, that number will remain the same until they go home, hopefully. 33 persons staying there together with 4 staff. No, together with our 4 staff at Napa. So under quarantine in Tacarigua, the 33 persons who come in from Barbados, hopefully if all goes well, they can hopefully be discharged sometime between next week, Monday and Tuesday. And that is where we are at right now. That is the picture in terms of what we have in our facilities, and that is the picture in what we have in terms of surveillance testing. So, Minister Cox, thank you very much, and over to you.
Thank you, Minister. At this time, Dr. Christine Carrington, Professor of Molecular Genetics and Virology and Head of the Department of Preclinical Sciences, Faculty of Medical Sciences at the University of the West Indies, will tell us what the scientific community knows about the COVID-19 virus.
Good morning. Thank you, ministers and other members of the panel, and good morning to members of the media and the viewing public. COVID-19 is caused by the SARS acute respiratory syndrome coronavirus 2, also known as SARS-CoV-2, but it's also commonly called the novel coronavirus or the COVID-19 virus. Now, viruses are infectious agents that replicate inside of living cells. They only replicate inside of a living cell, and there are estimated to be millions of different types of viruses. They infect all manner of living things. They infect plants, animals, microorganisms, bacteria. And to date, over 6,000 viruses have been described in detail. Now, the COVID-19 virus belongs to a large family of viruses known as coronaviruses that are naturally found in a wide variety of animals. Like many other viruses that have recently emerged in human populations, such as Ebola, H1N1, chikungunya, and even dengue, the COVID-19 virus is thought to have arisen from a virus that jumped from animals to humans and then acquired the ability to efficiently spread from human to human. Now, genetic analyses have shown that the COVID-19 virus is most closely related to other coronaviruses in bats, so it is almost certain that its ancestor was a bat virus, but it is still not clear whether that virus moved from bats directly to humans or from bats to another animal species and then to humans. That's still not known. Now, before the emergence of the COVID-19 virus, we knew of 6 other coronaviruses that infect humans. All of them are respiratory viruses, meaning that they infect the nasal passages and the lungs, and they are spread from one person to another, primarily by droplets created when an infected person sneezes, coughs, or even when they speak. Now, in order to infect a person, the virus has to get inside the body through an opening. It can't go directly through your skin. So, people can either get infected directly if droplets from an infected person enters their nose, their mouth, or their eyes, or they can get infected when they touch a surface where those droplets have fallen, and then they touch their mouth, their nose, or their eyes. Of the 6 human coronaviruses we knew about before this new virus, 2 were associated with epidemics of very severe disease, but these viruses were they were successfully contained, and they did not cause pandemics. Together, those 2 viruses were known to only infect about 11,000 people. We now know that the reason that those were more easily contained than the current coronavirus, the COVID-19 virus, is because they did not spread from person to person as easily as the COVID-19 virus does. Also, when those viruses infect someone, most people who get infected will become sick. And so it was very easy to identify almost all of the infected people and to prevent them from infecting others. With the COVID-19 virus now, it is estimated that without interventions like social distancing, quarantine, frequent hand washing, covering our sneezes and coughs, wearing masks, without those interventions, on average, every infected person would go on to infect about 2 to 3 other people. Now, that number is called the basic reproductive number, or R0 for the virus. And the aim of all the public health interventions is to move to a situation where you have an effective, that was the basic reproductive number. You want to move to a situation where the effective reproductive number, R, is less than 1. When it is less than 1, that means that the number of new infections is getting smaller and smaller instead of getting bigger and bigger. The other thing we learned that we didn't know when the virus was in China and when it first took hold in Europe is that most people who get infected with the COVID-19 virus show no symptoms, and also that these people and people who will eventually show symptoms but haven't done so yet can pass the virus on to other people. So also, while we've known for a while now that younger people and children in particular are less likely to get severe disease, 2 recent studies showed that they are just as likely to get infected as older people, and the levels of virus in their bodies, at least in those who showed symptoms, is about the same as in older people. So what that means is that even if they're not showing disease, even if they're young children who are likely to get severe manifestations, they can still spread the virus like everyone else. So what we have is a very contagious virus that can cause severe disease in some people, and that can be spread by anyone who is infected, including people who don't even know that they're infected. So currently, the only reliable way to tell if someone is infected with the COVID-19 virus is to use a technique called PCR that allows you to detect the presence of the virus's genetic material in a sample taken from that person. Now, this genetic material is like a hereditary blueprint. It's basically instructions for how to replicate that virus that the cell uses to make more viruses. And in coronaviruses, that blueprint, that hereditary blueprint, is in a molecule called RNA. And in addition to using the PCR approach I mentioned before to detect the virus's RNA and thereby confirm a diagnosis of COVID-19, it is also possible to read that blueprint by extracting and sequencing viral genetic material found in clinical samples. Now, viruses like the COVID-19 virus that have this sort of RNA as their genetic material, they frequently undergo mutations, which is a sort of natural genetic change. And when you have an accumulation of those mutations over time, you can track that, those changes by reading the sequence of the blueprint and recording and analyzing the virus's genetic material. Now, to date, despite widespread media reports stating otherwise, there is no reliable scientific data to suggest that the strains that have arisen as a result of this natural genetic change differ in infectivity or in their severity. Now, this doesn't mean that it can't occur, but at this stage it's not a major concern because the rate at which this virus accumulates those changes, those mutations, is low compared to other viruses, for example, compared to flu. What is more important right now is to prevent infections in the first place. To get that number R I spoke about earlier, to get it less than 1 and keep it below 1, keep it there. Now, the best way to achieve this is through vaccination. And right now, there are over 100 different vaccines under development, and about 12 of them have reached the stage of clinical trials. One of the most advanced, being developed by Oxford University, looks very promising. But even if this vaccine and the other ones under development prove to be effective in these trials, it will be at least a year before they're ready to be administered to the general public. So until then, the only way to control this disease is to keep that R below 1, and that it can be done through social distancing, quarantine, frequent hand washing, covering our sneezes and coughs, and wearing masks. Another important thing to note, finally, I also want to support calls for the elderly in particular, that high-risk group, to get their yearly flu shot. The flu shot is not going to protect you against the coronavirus, but it allows you to, it protects you against the flu, and you end up in a situation where you're not fighting 2 viruses at a time, and your lungs are much healthier, so that if you do get infected with COVID-19, you're better able to deal with it. Also, parents should ensure that their children, that they adhere to the immunization schedules for their children, the normal schedules, again, keeping everybody as healthy as possible, so that should you encounter the COVID-19 virus, you're in a better position to deal with it. And we don't want other diseases to be accumulating as well. And also, the last thing I would say is that homes for the elderly, I would strongly encourage you to adhere to the infection prevention control measures that have been developed by the Ministry of Health. You're responsible for a very vulnerable population, and it's important that we protect them. Thank you.
Thank you very much, Professor Carrington. Professor Terence Simongal, Dean of the Faculty of Medical Sciences, University of the West Indies, will speak about therapeutic options for COVID-19.
Thank you. Good morning, ministers,
Good morning.
Morning.
my colleague, Professor Carrington, members of the media, and the viewing public. When this virus visited us here in Trinidad in March last year, the chief medical officer... March this year, sorry. The chief medical officer turned to the faculty and asked us for the latest on therapy. And the report we sent in as of the 30th of March was that there is no really reliably active drug that we can rely on to treat COVID-19. The World Health Organization has come up with a study which they call Solidarity. And this is a large international trial that will be looking at options for therapy. It is proposed that the study be done throughout the countries in which the University of the West Indies is, and that would be Trinidad, Barbados, the Bahamas, and Jamaica. We have a committee that's across the four countries that is chaired by one of our colleagues, Professor Marvin Reed of the Mona campus. Apart from its international design, the study is also looking at 4 therapeutic options: remdesivir, ritonavir, interferon beta, and hydroxychloroquine versus standard care or usual care, whatever that is in the country in which the study is being done. Patients will be given the opportunity of enrolling in the study. Of course, they may say no. And if they say yes, they would have to sign a consent form. And of course, further information will be given to them. The study compares these drugs against the usual, what we call usual care or the standard of care. And if someone opts to go into the study, they cannot say which line of treatment they must get. It is what we call randomized, and the randomization process is done by the WHO. We hope that after this study, there will be clear evidence as to which of these drugs will help in the treatment of COVID-19. Thank you, Minister.
Thank you very much. Members of the media, the floor is now open. Remember to identify yourself and the media house you represent before posing your question. And we want to give as many of you an opportunity to pose questions to us, but that means in our limited time, we will have to give each media house a chance to get a maximum of 2 questions in. Once we have completed the pool and time allows, I will come back to you. So let us keep this in mind as we begin taking your questions. 98.1.
Good morning to the panel. Stephen
Morning.
Cummings, 98.1 FM. A question for Professor Simangal and one for Minister Dayal Singh. I'll first go with Minister Dayal Singh. Minister Dayal Singh, are you able to give a cost value on the outfitting of the National Racket Sports Center in Tacarigua, which we understand is about one in several alternative care facilities for COVID-19 patients' arrivals and stay as we move into the creation of the parallel healthcare system? And Professor Simangal, as the safety of our frontline workers remain of paramount importance, are telemedicine visits and the possible incorporation of the use of artificial intelligence being looked at as maybe other effective ways of delivering COVID-19 patient care in Trinidad and Tobago?
Okay, so thank you, Mr. Cummings. It's coincidental you asked this question because we did do a rough count about a week ago, just before the 33 Barbadians came in. At that time, we estimated the total cost of outfitting, treatment of glass, putting up partitions, buying of everything, staffing, food, will come up somewhere between $1 to $1.5 million that is infrastructural works, fixed costs. We had to rent a whole suite of executive bathrooms because the center only had 2 or 3 bathrooms. We had to rent all of that. So it's going to cost the taxpayer between 1 million to 1.5 just for that facility for the 2-week period. Hope that answers your question. Professor Simongo.
Professor
Okay.
Simongo?
You're asking about safety of frontline workers, telemedicine visits, and use of artificial intelligence. I can certainly speak of that from the point of view of the Faculty of Medical Sciences. As soon as this crisis erupted, we have done everything that we can to move towards online delivery of our courses, including our clinical courses. So we are certainly moving in that direction. There are certain gaps, as it were, with regard to the practicality of telemedicine, in the sense that in order to get an assessment of the patient that combines both the so-called subjective parts of the examination, which is the history, we can get that, but the physical part of the examination is still a bit of a challenge because it requires patients to have access to equipment. We are hoping over the next 2 years to be able to roll something like that out here in Trinidad and Tobago. I don't know if the minister would want to comment from the public.
No, I think you answered.
Okay, thank you. We move to Prior.
Hi, good morning, Prior Barry, AZP News.
Morning.
Dr. Carrington, I just wanted to find out about the reinfection rate in COVID-19. How prevalent is it, and does the person has to come back in contact with it in a service, etc. In that sense, and to the Minister of Health, the University of Oxford report was very telling, and I think credit should be given to you and the Ministry of Health. But it was silent in terms of schools. How would we treat when school opens? What measures would be put in place, for students, in classrooms that are very cramped? Can you just give us an idea what measures the ministry has for schools when it reopens?
So I'll take the second part first, and then we'll go to Professor Carrington. The Ministry of Health will be advising the Ministry of Education and therefore the Cabinet as to what measures can be taken. All those issues are under active consideration at the ministry at this point in time, and we will make those proposals to the Ministry of Education first. Thank you very much.
So your question about reinfection is an important one. There were several reports of people who had tested who had COVID-19, and then they had recovered, they had tested negative, and then later on they tested positive again. Now, people have used that as evidence to say that people are being reinfected. But from the beginning, scientists have cautioned that we can't be sure that they're being reinfected because it is possible that some of the genetic material from the virus remains in their body after they have cleared the virus itself, and that sort of genetic junk that's left over can be detected by the test. Now, the test that the test that you're using is actually trying to detect that genetic material, and there was actually a recent study, just read about it this morning, where they took material from people who were supposedly reinfected and checked to see if this so-called virus that they had detected was infectious, and they were able to show that it is absolutely not. So what's happening is those cases are due to the fact that there's sort of leftover junk in the body that can be detected. It's there at very, very low levels, and the test is very, very sensitive, so it might detect it, and then if the levels fluctuate a bit, it will detect it again. So it's not it doesn't appear to be a true reinfection. It seems that when people are infected, they do mount an immune response that would protect them from further infection. What we don't know is how strong that immune response is and how long it lasts. So those reports about reinfection, we have to look at them very carefully.
Professor Carrington, if I may jump off on Pryor's question, because there's a lot of debate internationally, and we could use your expertise. Is that where the debate about whether people are reinfected or whether the virus is reactivated? Would you be able to shed some light on whether it's a reinfection or reactivation of the virus?
Okay, I think the evidence so far shows that it is neither of those.
Okay.
What is happening is that somebody is getting infected. The virus, normally a normal infection, the amount of virus will go up in your body, and then the immune response kicks in, and the amount of virus that you have in your body will fall. And the whole time, what people are doing when they're following these patients is they're trying to see to know when the virus is completely cleared. So that's why we do these tests, to try and detect the genetic material from the virus to see when that is gone. And then we say, okay, and once we get 2 negative tests, we say that person is now clear. But it is possible that very small amounts of the genetic material can remain in somebody after the virus, the sort of infectious virus itself, has cleared. And those, that's what you appear to be seeing. It's not that the person has the virus and it's sort of come back or they've been reinfected. It doesn't appear to be the case right now. Right?
Okay. Thank you, Professor Carrington. Newsday.
Hello, good morning. How are you?
Morning.
Good morning.
Morning, Carla.
Carla Bridglal from the Newsday. Professor Simongal, can you tell me a little bit more about this this study? First of all these drugs, none of which I can pronounce the name properly, they've been, bandied about in the media, questionable, whether or not they're safe or not. First of all, tell me, how did we become part of this study? And also, are you, is the region confident that enough people, given the sort of news around them, will be willing to take part in it? And, just a little more about this study in general, about what it would entail, how long it will last. And Mr. Dialsing, do you have an idea of the cost per person, per patient, sorry, of each COVID patient? The cost each COVID patient has cost the country? Gosh, sorry about that.
So I'll take the second question first, because the answer is easy. We have not calculated that as yet. We are just spending money. When this is all over, or maybe sometime soon, we could do that. But it is going to be significant.
So a bit more about the study. So the length of the study will be the length of the prescription really for the drugs. So one of them will be about 10 days, another one will be about 7, another one will be about 2 weeks. So, so it depends on which arm of the study you are in. Now you asked why the Caribbean, I think, and I think it's important for us to note that a lot of times when drugs are used throughout the world, they are based on studies that are not done on our patients. And we really don't know how our patients react to these drugs. We assume it's the same as in North American countries and Europe, which is where a lot of studies are done. So this is a chance for us to be part of an international approach to treatment. Will we get enough patients involved in the study? Well, time will tell. But other studies, smaller studies that have been done here in the Caribbean, we have had enrollment of patients, and it's up to the public to decide if someone is ill, if they wish to take part. No one is going to be forced to take part in any study. Have I answered your question?
Sure.
Okay.
Okay, we move to TV6.
This is actually Nika Pasanal from MOOP.
Okay.
Good morning, everybody. My question is for Professor Simongal. You had mentioned that the comparison to the drugs will be standard care, but just to give me a better picture of that, what exactly constitutes what we call standard care, just so we understand that comparison?
So the standard care is what is being offered right now in the hospitals. So if a patient comes with what people think could be a pneumonia, they may get antibiotics. They will have drugs to treat their fever and whatever other symptoms that they have. So whatever is the standard of care is what is going to be compared. As far as drug protocols or study protocols go, we have to have very clear definitions of these things. And no one has been enrolled yet because the submission has gone to the various ethics committees where these matters have to be confirmed and sorted out.
Okay, we move now to TV6.
Hi, Rynessa Cutting TV6 News. Hello?
Yes, morning,
good
morning,
morning. Good
morning,
morning.
morning.
Good morning. We're hearing you.
Good morning. My questions are to the minister. Now, the Nurse Association is asking for a number of benefits for their members, including hazard allowance, death benefits, and the like. Could you say whether you have officially received this communication and what is the ministry's stance on this?
So as I indicated...
And also, given that we are seeing that the virus is manifesting in new ways, specifically the blood clots and the strokes, are we going to revise our protocol where it concerns healthcare workers at the accident and emergency room in terms of protocols concerning PPE and these things?
Sure. So I did indicate 2 days ago that the RHAs, who are the employers of all healthcare workers, we are not looking at any one category, will go to the CPO to do just that. And we have, yes, we did receive the correspondence from TTRNA, and we said publicly 2 days ago, let the collective bargaining process work, and they will go to the CPO. Healthcare workers with PPE, there's absolutely no shortage of PPE for healthcare workers. We are deepening the process. As a matter of fact, I left a meeting at the ministry now, which is going on right now, where we pulled in all the infection prevention control professionals from all the RHAs to assure them, and they have told us in no uncertain terms there is no shortage of PPE, contrary to what is being bandied about. These are public officers who met with us this morning. They have agreed, they volunteered the information. There is no shortage of PPE. What we are doing to protect them is stratifying healthcare workers according to risk and make sure they have the appropriate PPE according to risk. And we are deepening that this morning with the workshop which is going on right now to develop future policies moving forward to protect healthcare workers. I hope that answers your question. Thank you very much.
Express.
Good morning, Camille Hunt, Express.
Morning.
Good morning.
My question perhaps for Dr. Carrington is, in any research on whether COVID-19 can be vector-borne? Can it be spread by mosquitoes or ticks, etc.? Do we know anything about that? And for Dr. Simangal, why is pneumonia such leading cause of death? Is there any way to prevent it in COVID-19 patients?
Dr. Carrington?
Yes, thank you for your question. You're asking whether there's any evidence that the COVID-19 virus can be spread by vectors like you said, mosquitoes and ticks and things like that. There's no evidence for that. I don't know of any coronaviruses that are spread in that way. The being able to be spread by a mosquito, in order to be able to spread by an insect, say a mosquito, the virus has to have the ability to enter and replicate in the mosquito. It has to be able to multiply in the mosquito, and then it has to go from there, from the mosquito to the human, and then replicate in the human. So it has to have the ability to replicate in more than one, in two very, very different hosts. One of them is an insect, and the other one is a mammal. And coronaviruses are not known to be able to do that sort of switch. They can move from one animal species to another, so from a bat to a human, or from a ferret cat to a human, etc. But not they're not vectored viruses. Thank you.
I guess the next one is for me.
Yes.
Why is pneumonia a leading cause of death in COVID patients? So just to get the context, the leading cause of death in the Caribbean is in fact the non-communicable diseases. Pneumonias are a leading cause of death in COVID-19 patients. The reason for this is that in a small proportion of patients, the virus gets into the lungs and the response of the immune system of the body to the presence of that virus is excessive. In a way, in responding to the body, to the virus, the immune system also attacks some of the cells in the lungs. And this leads to the pneumonia, and in a few cases, it also leads to death. It is the fact, as Professor Carrington said, that this is a respiratory virus, so it attacks predominantly the respiratory system. And hence, the effects are seen there. Thank you.
Thank you very much. 98.1.
Thank you so much again, Stephen Cummings, 98.1 FM. Dr. Carrington, are you able to explain the difference between a virus and a bacterial infection, and possibly approaches to treating each or both in this regard, as we continue to talk about the issue of COVID-19?
Thank you. That's a very good question. So viruses and bacteria are very different entities. You could consider them to be as different as a mosquito and a dog. Okay, the virus itself. Viruses are infectious agents that have to get inside of a cell, and then they replicate inside the cell. So they're called intracellular parasites, and they use the machinery inside of your cell to make new viruses. Bacteria can multiply and divide outside of a living cell. They're much larger than viruses, and they have their own machinery for replicating themselves. So in terms of treatment, there are a lot of antibiotics that you would use to treat bacterial infections, and those antibiotics work by targeting the machinery that the bacterium uses to replicate. And that machinery is very different from for example, a human's machinery. In the case of the virus is using the machinery that it finds inside of the cell that it is replicating in. And so the drugs that you need to prevent a virus, called antivirals, would have to target that machinery. There are fewer antivirals available than antibiotics, the ones that kill the bacteria, because the antivirals are targeting, the machinery that they're targeting is the same machinery that we use for our cells to replicate. And it's very difficult to find drugs that can differentiate between what the virus is doing and what your cell is doing. So it's been done. There are some things that are unique to the virus that you can target, but in general, there are fewer antivirals. I hope that answers your question.
Minister?
No, yeah.
Yes?
But could we just follow, because this is a very interesting conversation. So, Professor, as we have you here, is that one of the reasons why there are no simple, safe, effective treatments for like HIV, which the world has been battling for 30, 40 years now?
Well, in fact, HIV is the type of virus that is different from the COVID-19 virus, and there are several targets that have been used to prevent, not to prevent, but to treat HIV infection. So they're in fact very good treatments for HIV. The thing with HIV is that when the virus gets into your cell, the virus genetic material gets sort of integrated into your own genetic material. And so getting rid of it entirely is difficult. But you can sort of suppress the virus and prevent it from replicating too much. So that's why people who are on HIV therapy with these we call them antiretroviral drugs, that's why they have to stay on the drugs for basically a lifetime, because you're constantly trying to just keep that virus level down. You don't actually get rid of the virus entirely. There are other treatments, sort of gene therapy treatments that people have used to try and get rid of the virus entirely. But so.
Thank you very much, Professor. I have a question. I'm not too sure who this question is for, Minister. Person wants to know, after the use of cataflam, and there's a drug called, I think it's prednisolone.
Prednisolone.
Prednisolone?
Yeah. Mm-hmm.
Right. How soon after can COVID-19 pose additional threats to a patient?
I will let Professor Simongal take that one. He's a medical doctor. I'll be getting free medical classes this morning.
Okay, thank you. I'm not aware that cataflam has any particular interaction with the virus. Cataflam is a painkiller. With regard to prednisolone, again, we don't have any clear data now. Some infections are more common in patients who are on drugs that interfere with the immune system, and prednisolone does that. So I guess depending on the dose of prednisolone, there might be some interaction with the virus, but the data that has come out so far hasn't particularly picked up on the use of this drug.
Let me just put a little more, some meat on that. Prednisolone is what you call a steroid. It dampens the body's inflammatory response. Could be used from anything from asthma, arthritis. Cataflam belongs to a class of drug called NSAIDs, I believe. And what NSAIDs mean? Non-steroidal. So prednisolone is a steroid. Cataflam is non-steroidal. It's basically simply, again, an anti-inflammatory and painkiller. So it's two different classes of drugs. Okay?
Thank you. We move to Sunil at CLC.
Hello, Sunil Lalas, Caribbean Lifestyle Communications. Mr. Dialsing.
Yes.
Reading a report here, businesses eyed phased reopening from Monday, that's May 4th.
Sorry, say that again?
Yes, apparently businesses are eyeing the phased reopening from May 4th. Article in the newspaper where the TNT Chamber Industry CEO, Gabriel Faria, he's saying he's submitted a safe to open protocol to the subcommittee, which is a subcommittee to the recovery roadmap for TNT. He's saying that he's optimistic the document could work, given the recent report from the University of Oxford saying TNT was more ready to exit the lockdown measure than most countries. Would you care to comment on that?
Sure.
And also, with regards to the last case, the 116th case, it said it was pending epidemiological investigation. Has that been resolved?
Okay. So I'll take the last part first. I haven't had the benefit of a report on that as yet. I will certainly ask the Chief Medical Officer. He should be here tomorrow. Okay, the optimism that Mr. Gabriel Faria is alluding to, that optimism, I don't want to say it is misplaced. What I will simply repeat is that the Prime Minister has indicated he will listen to the science, he will listen to the data, and the same way we made careful, deliberate steps, which the Oxford report has recognized, in reverse, we will make careful, deliberate steps based on the science. The decision to open up, how we open up, when to open up, where, will be made by the Honorable Prime Minister when he is satisfied that the public health officials, led by the Chief Medical Officer, presents him with some data.
Okay, I think there was a first pass to the question.
I answered that, yes. Thanks.
Okay, good. Guardian Media Limited.
Hi, good morning. Good morning, Minister. Good morning, Dr.
Morning.
Christopher from Guardian Media. My first question, I'm not sure if it would be best directed at anyone at this panel, but I received some concerns from some essential leaders more attached to the National Security Ministry who are expressing concerns about the ability to get to their jobs late at night due to limited traveling options. So I don't know if you could pass on that concern to your cabinet colleague. My other question would do with the decanting centers and such. I just wanted to get more insight in terms of the preparation of those centers, what procedures are done, and especially what kind of sanitization is done after a patient is discharged.
Sure. So I will pass on your concern to the Minister of National Security. Dr. Mariam Richards was here yesterday and gave a detailed breakdown as to how these decanting centers are set up. And yes, sanitation is a crucial part of infection prevention control. And we have companies that do everything from steam cleaning to bactericides to everything. So all these facilities are cleaned. So there's should be no concern there. Thank you.
I-95.5.
Good morning to everyone. Whithfield Turner from I-95. Just to confirm, Dr. Carrington, for the persons who would have contracted COVID and would have run the full gamut, gotten their 2 negatives and so forth, you mentioned about residual portions of the virus still in them. Just to get it clarified, is it in sufficient quantities that they can again reinfect other persons, or is it that it would just be there basically below the radar as it were, and in time it will simply fade away and we don't need to worry about it?
Right. So what I said is that you have small amounts of the genetic material from the virus sort of remaining in cells, okay? And sometimes you're able to detect that. The small little fragments of the genetic material cannot replicate. You need the whole virus to replicate, so the virus to multiply in one cell and then burst out of that cell and spread to another cell and then, become transmitted from one person to another, etc. So that's what you call the virus is infectious. You have an infectious particle that can be transmitted from one person to the other. If you have a small piece of the virus, what they seem to be detecting is these little tiny pieces that are not infectious. So, no, those small fragments of the virus's genetic material are not infectious. That's what they've shown. Now, what I should mention is that all tests have an error rate. These tests are very, very sensitive, and we are taking them to the limits of their detection to try and see that all of the virus is gone. So it is possible that you may have a situation where you get a false negative. So you test somebody, it looks negative, but really, because of how you've done the test or because of how the virus was operating that day in the person's body, you missed it and it's back. But I think the evidence suggests that these sort of detection of virus long after a person has had 2 negatives, it's not the intact virus that can infect someone. It is small fragments of the virus that have remained in the cells, and as those cells die, all cells have a life cycle. As they die, that material is released, and we might be able to detect it.
Okay, we move to back to Newsday.
All right, just 2 very quick questions. First, Professor Simango, I don't think you said the date that this study will start.
Okay.
Could you just clarify that? And for Minister Dialsingh, the Jamaican cabinet has agreed to allow final year, they've taken the decision to allow final year medical students at UWI Mona to be part of the COVID response. Is that something we are considering?
Well, it's a good thing you have Professor Simangal here. He could answer both questions because he is the Dean of the Faculty of Medical Sciences at UWI.
Thank you, Minister.
No problem.
The date of starting of the study, we still have to get approval of the Ethics Committee. The Ministry of Health's Ethics Committee handles national studies of this type, and then the UWI Ethics Committee. So it's been submitted. And the Ethics Committee, we don't want to put any pressure on them because they must look through the study in detail and be comfortable for it to be carried out here in Trinidad and Tobago. And the same is being done on the Mona campus, the Bahamas, and in Barbados. With regard to, can I just get the question you asked about Jamaica? I didn't quite get what you said about the Mona campus.
Oh, we're not hearing, huh?
We're not hearing you.
The use of final year students.
Right, okay. Okay, right. I think that somehow the use of final year students may have become a little extended in a way that was not intended by the faculty at Mona. I did inquire about that because I heard about it. What they were doing was to ask the students to telephone some of the patients to make inquiries to assist in contact tracing.
Oh, okay.
But the students are not on the wards right now, involved in patient care and have no direct contact with patients. With regard to us doing, we can participate in that. There has been no need. I mean, the ministry has been handling things over here without the need for any extra help. They haven't approached us. If they do, of course, we'll consider it. But our position was that the students should not get unnecessary exposure in a case where they are not an essential part of the service. Thank you.
Thank you. We move to 98.1. One question, please.
Yes, just one question to Dr. Carrington. Dr. Carrington, you mentioned in your opening presentation about the origin of the virus, and you mentioned bats, animals generally. Should we be going by way of caution in the consumption of meat generally, seeing that we have discovered animals being among the first carriers? And should a change in meat consumption also be part of this new normal that we've been talking about?
Okay, so the recommendations have always been that when you're dealing with meat, the meat is cooked properly. If you cook it, it kills bacteria and viruses. The real risk comes from wild animals. So it is all the wild animals out there that have a lot of viruses in them, like we do. We have a lot of viruses as well. And what happens is when we encroach on them, or we consume them, or we butcher them, there's always the chance of getting infected by viruses that they carry. So it is not that the animals are any more, they do have a lot of viruses, but the problem is our encroachment into their habitats and our destruction of their habitats. So what we're doing is we're creating more opportunities for viruses to jump from animal populations into human populations. The other big factor that helps this sort of emergence is when the fact that we travel so quickly and so widely around the world. You can move from one place to another in the world in less than a day. And in fact, when somebody gets infected, the chance of them moving that virus and spreading it to other people and it is much greater now than it was before. But to come back to your question about food, it's always recommended that meat be cooked properly in order to kill any bacteria or viruses in that meat.
Thank you very much. I have a question online. I was just reading it actually. Sure. Minister, why don't we explore the option of getting test kits from Senegal and Philippines? And many countries have sent back faulty test kits to China. This is what the person is saying.
So the test kits that were sent back to China originally were rapid tests. The test kits we are getting from China are approved by CARFA. We are also getting test kits, as I indicated yesterday, from the United States. PAHO is sending us test kits. So we are currently well supplied with test kits, and we will explore every avenue to get proper PCR test kits from any part of the world once test kits are approved by WHO and CARFA.
Thank you very much. One question from TV6.
Hi. Could the doctor state what in particular would give someone's immune system a better fighting chance as opposed to someone else, not counting persons with underlying illnesses? Is it that certain deficiencies of particular minerals or vitamins that you could highlight that would make you succumb more easily to a virus?
Which doctor will be taking that?
Okay.
Prof.
Okay, so viruses, well, and bacteria actually attack the body, and obviously if the immune system is not as strong as it is, there's a greater chance of entry and causing disease. So what do we say? Well, you have to have a balanced diet. That's important, in which there must be minerals and vitamins. So if you eat vegetables, and we mentioned meat, yes, for protein, and a wide array of vegetables and fruits, you will get all of the vitamins and minerals that you need, and then your immune system will respond appropriately to infection. Thank you.
Thank you very much. At this time, I'd like to ask the Minister to give us a closing statement, please.
Thank you very much. So, ladies and gentlemen of the media, the wider listening and viewing public, I really want to thank the two experts that we brought in from the University of the West Indies this morning. They both gave us very good lectures, if I may use that word loosely. Thanks to Professor Carrington, Professor Simangal. I think we have been educated. The key message, again, as we go out and we leave this press conference this morning, as we move forward into a different phase of treating this virus, we must not take the numbers that we have and the report that we got from Oxford University yesterday as a victory lap. We are not raising the victory flag. We have not planted any flag to say we have conquered the virus. No country in the world has so far conquered the virus, eradicated the virus. What we have done is suppressed the virus. Am I correct, Professor? We have suppressed. Yes. When you suppress, it means you are keeping it down at a certain acceptable level. And this is where the Prime Minister has said, what risk are we willing to take as we ponder how to get back to some state of reopening of the economy? We will not, hopefully, be making rash decisions based on misplaced optimism, but the decisions are going to be based, as they have always been based, on the science and on the data. I want to urge all of Trinidad and Tobago that this is a time to rally around your government, which has your best long-term interest at heart, your best long-term interest. It is very easy in this situation to make a short-term decision and be popular. We are not in a popularity contest. We are in a contest to save lives. And so far, so good. Stay the course with the Prime Minister and his government. And as I've said on these platforms over and over, if we do that, we will come through this together, stronger and better. And as Minister Cox always says, and I will steal your line here if you don't mind,
That's okay.
May God bless Trinidad and Tobago. Thank you very much.
Thank you very much, Minister, for this statement. And we have come to the end of today's virtual media conference. Do remember that the Ministry of Health and the Ministry of Communications are your only credible sources of government information on COVID-19. This is a time many citizens are clamoring for authentic, trustworthy information on COVID-19. And we understand and want to help you cut through the clutter. No need to scroll past non-COVID-19 related information on our website to get the facts you are looking for about the virus. With this in mind, the Ministry of Communications created a website that has all things COVID-19 related. It is a one-stop shop for all the releases from the Ministry of Communications, all the releases from the Ministry of Health, public health guidelines, public health notices, the highlights from the day's media conferences, just in case you missed it, along with videos, podcasts, and other educational material. And you can access this website at www.covid19.gov.tt. I am Donna Cox, Minister of Communications. Thank you for joining us today as the government continues its efforts to flatten the curve and beat COVID-19. Stay home, stay safe, and may God bless Trinidad and Tobago.
And that was an update on the COVID-19 pandemic from the Ministry of Health. A quick review of some of the key points